Okay, let's get started. Sorry, you're fine. Okay. So yesterday we learned salt balance, how we can affect salt reabsorption through diuretic use. So make sure you understand when you're studying where those diuretics work, what part of the nephron they exert their properties for. We talked about water balance. What hormone is responsible for water balance? ADH, vasopressin, that's responsible for the water balance. Now let's talk about how we actually regulate our extracellular fluid volume. Remember, the main homeostatic variable for the kidneys is extracellular fluid. Okay? So, therefore, that's going to have an effect on your blood pressure. If the kidneys start dumping out fluid like crazy, what happens to your blood volume? It drops because you're getting rid of fluid in the urine, and then you're getting rid of it by peeing it out. If you lose volume of blood in the system, what happens to your pressure? It goes down as well. So kidneys are very, very important in regards to blood pressure monitoring as well. We use ECF as a function of our total sodium in the ECF. That's why sodium is very important, and we're going to learn today how sodium really has an important effect on potassium reabsorption and management when we start getting to potassium in a little bit. So any type of edema formation we get usually has a problem with our sodium balance. You'll see we're going to talk about natriuresis. We've already mentioned diuresis. So natriuresis, what do you think we're going to be altering with natriuresis? Sodium. Where have you heard, if you work in the ER, you may have heard the word natriuretic before. Anyone heard of a BNP? You do it for a monitor of like overload status. Well, what does BNP stand for? Brain natriuretic peptide. And the way it works is to get rid of sodium, and if we get rid of sodium, water goes with it, and we can diurese that way. So diuresis with a natriuretic peptide is from internal stuff. Okay. So effective circulating volume. Remember, we have sensors in the kidney dealing with what's the structure, what's the apparatus that senses the volume coming in through the kidney? Macula densa. Okay. Okay, the macula densa is what senses the effective circulating blood volume. Obviously, it's in the kidneys. If we have too much, we change our renal sodium excretion to get rid of the excess fluid, depending on what's going on with the volume of blood at the time. Okay, so here just talked about the sensors right here with the macula densa as far as less stretch of the afferent arterioles, then for renin gets released, and the renin angiotensin 1-2 aldosterone cascade starts. And obviously, plasma osmolarity will be increased if more sodium is retained. Osmolarity goes up. When osmolarity goes up, it's sensed by the hypothalamus to release what hormone? ADH, causing water retention, which will increase our extracellular fluid, which is going to dilute out that sodium. So when we're talking about concentrations with regards to urine, remember it's the concentration of the solute, not the number of solutes. It's always the concentration is what changes. How do we respond to low circulating blood volume? Obviously less pressure seen in the macula densa, releases renin, and this whole entire axis starts. The renin, angiotensin, aldosterone axis. We also have stimulation of our sympathetic nervous system. low blood volume, how can we raise our pressure in the system? What trick can the sympathetic nervous system do to our vessels to maintain pressure? They'll constrict. So we have low blood volume. By constricting our vessels, now we can maintain a constant pressure. If our vessels were dilated and our blood volume dropped, what's going to happen to your patient? They're going to pass out. There's no blood going to the brain. So with low blood volume, that's why you have anyone here experience those vasovagal syncopes? People who see blood, they pass out. So vaso refers to what? Vessels. Vagal is what nerve? Vagus. Is vagus nerve parasympathetic or sympathetic? Parasympathetic. So if you start activating your parasympathetic system, what's going to happen to all of your blood vessels? They're going to dilate. So they're going to blow up real big. Well, if you don't have the volume to get through all that or the pressure maintained, your pressure bottoms out, no perfusion in the brain, and you pass out. That's a vasovagal syncope. The parasympathetic system took over, caused mass dilation of your vessels, not enough pressure there, and you pass out. You can come in, you're fine. Also, with low circulating volume, increased ADH secretion. What's that going to do? ADH comes out. What's going to happen to our blood volume? Increase your blood volume. Remember, it's anti-diuretic. So we're going to keep all the water in the blood volume. So by having ADH come back out, we're going to keep the volume in the blood, raising our blood volume, raising our pressure. So when we have low effective circulating volume, what do you think the makeup of that urine is going to be? Is it going to be concentrated or dilute? Concentrated, because the water is staying in the blood, not going into the urine. The urine is a consequence of what's going on in the ECF. It's just a way we can get rid of excess stuff, and we do it through the urine. And increased fluid retention via all those Starling's forces, dealing with the push and the suck and all that fun stuff. So this is a really good diagram that goes over what happens and all the feedbacks when we have our controlled variable of low effective circulating volume. It's going to be sensed by the juxtaglomerular apparatus. Okay, is this the more common one, nephron, or the least common nephron? The juxtaglomerular nephrons. Least common. About 15% of your nephrons are these juxtaglomerular nephrons. Why are they special? Where do they go into? The medulla. The renal medulla, these juxtaglomerular apparatus of the nephrons, they go deeper into the medulla. Therefore, when we have instances of low circulating volume, that juxtaglomerular apparatus will sense that. You can even store some blood in those areas to kind of help resist low blood volumes. So that's the juxtaglomerular apparatus within the kidneys. The main goal is to get renin out. That's the goal. When you get the renin out, it's going to cause renal sodium and water retention. That is the job of aldosterone. Aldosterone favors sodium reabsorption, and we know that wherever sodium goes, what goes along for the ride? Water. That's the job of aldosterone. So on your exam next, or in a couple weeks or a month, whatever, I forgot when it is. If I tell you the job of aldosterone, will it cause hypernatremia or hyponatremia? Hyper. We're retaining all the sodium. What's going to happen to the potassium? It's going to go down. The blood, you're going to become hypokalemic because aldosterone is kicking up. Remember, at this point in the common collecting duct, under the influence of aldosterone, there are two ions that are there, sodium and potassium going in opposite directions. Aldosterone will influence that to cause more potassium loss in the urine, and you retain more sodium. When you give spironolactone, which is the aldosterone antagonist, it does the opposite. Remember, the spironolactone is a diuretic, potassium-sparing diuretic. Potassium sparing because we cut off those gates, the sodium and the potassium exchange that goes on, we shut that off. So renal sodium water goes up. Obviously, our MAP is going to go up as well. We have low pressure baroreceptors. That's going to be sensed by the hypothalamus eventually. So we're going to increase our ADH secretion, and we all know what ADH does once it gets out. Vasoconstriction, right? Through what receptors in vasopressin? There's two, V1 and V2. Which one causes vasoconstriction? 50-50. V1. V1 is the vasoconstriction. V2 is the one that deals with the aquaporin channels at the kidney. We also have high pressure baroreceptors, which will kick in our sympathetic nervous system. What two hormones are coming out? Norepinephrine and epinephrine. And they cause, obviously, because they're sympathetic, we're going to get cardiac excitation. And we're going to get vasoconstriction, mainly through which one? Epi or norepi? Norepi causes vasoconstriction through what receptors? Alpha 1s. Okay, norepinephrine has an affinity for alphas, which are in the vasculature. Okay, remember, beta 1s are in the heart, beta 2s are in the lungs. One heart, two lungs. That's where those are located. The alphas are in the periphery. So this is what happens with low effective circulating volume. A great review slide. If you understand this, you understand the mechanisms of what our body will do with low. Now, let's talk about when we have volume overload. We have too much fluid in the system. Congestive heart failure. We can't pump the blood, we fill up with blood. We get edema. Renal failure. You can't filter out the blood. The GFR goes to nothing. You're not filtering anything. You're not producing urine. All that excess fluid stays in the body. So what does our body do when we're fluid overloaded? Well, all of these things have no effect because they're all due to help increase blood volume or increase your pressure, bring things back up again. But we're high already. We don't want renin to come back out. We have to get rid of fluid now. Okay? We still have changes in our Starling forces because now we have increased hydrostatic pressure in the glomerular capillary and also decreases your oncotic pressure because we're in high pressure. High volume, high hydrostatic pressure. Whenever you think of hydrostatic pressure, it's always volume pushing out, remember? So it's the volume of blood. If you have more blood, more hydrostatic pressure. They always go together. This causes reduced fluid reabsorption and allows more fluids to be excreted. Is that what we want? If we're excreting more fluid and we're already volume overloaded, yes, we want that. That's a great mechanism. We can get rid of fluid that way by obviously increasing the fluid loss in the urine. We reduce the reabsorption of the fluid so it stays in the urine and we just get rid of it. Here is our atrial natriuretic peptide. ANP is also secreted. ANP, guess where it comes from? Atria. The cause, what happens when you have volume overload to your chambers of the heart? Remember we talked about increased preload. What does that do to the stretch of the heart? Increases that stretch. And therefore, when we increase the stretch of that left ventricle, what happens to our calcium sensitivity? Increases, so we have a more forceful contraction. The atria also get stretched when they're being overloaded for a long period of time. The atria, by themselves, will release this hormone called atrial natriuretic peptide in a way to try and get rid of this fluid volume. Secreted from cardiac atria in response to the stretch caused by our increased blood volume, mainly the venous side. That's where it comes back to the right atrium. Promotes natriuresis, sodium loss in the urine, by increasing the GFR, so more fluid is getting into the kidneys, Whenever we increase GFR, glomerular filtration rate, that goes up, we're filtering more and more fluid, which we want. And it decreases sodium reabsorption. So if we decrease the sodium reabsorption, where's that sodium going to stay now? In the urine. If sodium is staying in the urine, where's the water going to stay as well? In the urine. So therefore, we're able to get rid of that fluid, pee off some water, get rid of it, and try and bring our blood volume down to a manageable level. That's the goal of atrial natriuretic peptide. And that's what it does. So in this one, the only one we have to worry about is just the ANP. Renin does nothing. We don't want renin coming out, so therefore this is why it's inhibited. Renin's just going to, what's renin going to do if that gets out to our blood pressure? Bring it up more. We don't have too much volume. We don't need any more. Let's get rid of it. ANP will do that. BNP, brain natriuretic peptide, obviously is related to ANP. It's called brain instead of ventricle. It's called brain because they first found it from the brain. Later, ventricles also produce it. BNP is more potent than ANP. We use it as a marker of fluid overload. One of the ICU drugs we can give to people who are in severe heart failure, fluid overloaded, they're swollen everywhere. PAs, when you do your JVP, you can see the entire jugular vein distended while they're sitting in a chair. That's how fluid overloaded they are. They'll be sitting in a chair, you can see the whole cord right there. Those people need to be diuresed. One of the drugs we give is called Natricor, which is a form of BNP. We just give it to them, and it helps diurese them as well. Again, this is not on your test. This is just reinforcing the things that we're learning and putting it in a clinical environment. So you actually, maybe some of you have seen that, and now you know what it does. Any questions about what our body does with high volume or low volume and the changes? High volume, just ANP for the most part. Low volume, your renin system comes out, ADH comes out, sympathetic nervous system comes out to bring your volume back up again. Okay, so now we're going to move on to some electrolyte homeostasis. This is going to go real fast so we get to potassium. Magnesium is very, very important. It's a cofactor in a lot of our enzymatic reactions. Think of magnesium very similar to calcium. They're both 2+ ions. Usually they work together. They're going to be related to a lot of things, and that's why at the end, loop diuretics can also cause loss of magnesium as well as calcium. They go together. Not all the time. Magnesium doesn't cause contractions, but they're 2+ ions. They're in a lot of areas together. Plasma magnesium is regulated by the balance between intestinal uptake. So what are we getting from our food that we're eating? That's the only way we can get magnesium. Our body doesn't produce it. You have to eat it. And how much we excrete. If they match, our magnesium levels are constant. If they don't, then you start getting some abnormalities. Only 1% of magnesium is actually in our extracellular fluid. The majority of it is going to be in the cells or in the bone. And the majority of reabsorption for magnesium, thick ascending limb, and the distal tubule. So towards the back end of the nephron is where magnesium is reabsorbed. That's it for magnesium. I told you these are fast. Renal urea handling, so our BUN, plasma urea concentration. It's an end product of nitrogen metabolism. What has nitrogen in it? Proteins. So proteins remember that's why, our creatinine is a function of muscle metabolism. BUN is also there. Urea excretion depends on the flow rate, on urine flow. During antidiuresis, we're going to reabsorb all that water. Urea concentrates in the lumen. Therefore, we have a diffusion gradient for urea reabsorption. So remember, we have the lumen, and we have the blood. In this case, we have a diffusion gradient for urea reabsorption, increased BUN with increased ADH. So we have urea, big concentrations out there, small amounts here, starts building up. So we have a diffusion gradient, so urea starts going into the blood, and that's why your blood urea nitrogen goes up. Therefore, BUN is a marker of dehydration. If someone's BUN is elevated, but the creatinine is normal, dehydration. Because the kidney function is still good, we're just building up BUN due to dehydration. So therefore, I just talked about then, just reabsorbing water to stave off dehydration. So that's where BUN comes into play. Just know if it's elevated without an elevation in creatinine, it's due to dehydration. Renal calcium handling, mainly under the influence of parathyroid hormone and vitamin D. These are the big ones that really play a role with calcium homeostasis. Because of the way that these hormones are, we are finding that calcium is found in different forms in the blood. 45% is just free calcium floating around the blood. 45% are bound to plasma proteins. So if they're bound to a protein, will this ever go into the glomerulus? No, it's a protein. It doesn't get through. And 10% is bound to anions like citrate or oxalate. Calcium oxalate can cause kidney stones. It makes a mineral. Calcium is a mineral. If it gets out of solution and it binds to oxalate, it forms a crystal. A crystal gets big enough, starts causing blockages, you got a kidney stone. If it leaves the bladder, it gets stuck in the urethra, now you have an impacted kidney stone. All that fun stuff happens after that. So we were very careful about calcium management. One last thing, on your exam, remember for tomorrow, there is the lab values are always going to be there. So if you have a question about labs, if they're in range or not, you have a lab value reference sheet that you can access at any point to know is this within range or out of range. So all the lab values are there at the top. So if you don't know what I'm talking about, look tomorrow. You'll see a link that says lab values. You click on it. You can use it within Lockdown Browser because it's enabled within Lockdown Browser. So as lab references, they're there. So this part right here, they're bound to plasma proteins. What do you think is going to happen if someone has liver failure? What are they not going to make? Albumin, the protein. If we don't have enough proteins floating around, will calcium have anything to bind to? No. So you'll see changes in calcium levels as well when you have liver problems because they need the protein to be floating around. So other things to keep in mind, again, with these proteins, they're so important. Learning all the different functions of them, what they're doing, will help as well. So the filtered load, obviously a product of the GFR and our free plasma concentration. Why the free plasma? Why are we only worried about free plasma at this point? Because the one bound to protein can't get in the kidney anyway. So only the free ones are the ones that can get dumped into the Bowman's capsule, into the ultrafiltrate, and then go through. Same thing with magnesium, thick ascending limb and distal tubules where calcium reabsorption occurs. And because of that, obviously we know PTH and vitamin D play a role. Thiazide diuretics will stimulate calcium reabsorption in that distal tubule as well. So thiazides will have a role with calcium a little bit as well. I talked about this already, so like calcium oxalate are the big ones that cause kidney stones. That's all you gotta know about that. Renal phosphate is another one. Okay. This again, inorganic phosphate of what we eat and any exchanges with the bone as well. Phosphate is very important in bone formation, as well as calcium. Phosphate is there as well. There's two major forms. 80% is alkaline phosphatase. Alk-phos, we use that as a marker of liver function as well. And 20% is acid phosphate. Only 20% is actually going into the urine. We reabsorb most of it through this sodium phosphate co-transport, and it's only in the proximal tubule that this occurs. Very dependent on GFR, as with all things are, because if you have a good perfusion of blood going into the filtrate, then you can filter more things. When GFR goes down, you can't filter as much anymore, and those concentrations start going up. PTH is the most important regulator of phosphate, and we'll get into that a lot more when we get to endo, when we start talking about those hormones. Okay, next one up is our potassium balance, and obviously we are very, very, very careful of potassium. What do we learn about day one of physio? Why is potassium so important? Resting membrane potential. Remember all that stuff? I try to block it out already, but you got to remember all that stuff. Okay, 98% of all of our potassium is in the ICF. That sets up our concentration gradients. Normal range of extracellular is 3.5 to 5.5. So that's your normal ranges for potassium in the blood, 3.5 to 5.5. Obviously, we know this. K has a very strong influence on that resting membrane potential. So there's two different ways to approach potassium balance. One, internal and external. The internal is just between the ICF and the ECF. We can move potassium in and out. Or we can alter how much potassium we excrete in the urine. And that's external potassium balance, or homeostasis. Aldosterone is the key hormone controlling potassium balance. And remember, where does aldosterone have its effect in the nephron? Common collecting duct, right at the end. Late distal tubule going into the collecting duct is where aldosterone has its effects. If we increase our extracellular potassium, it's also going to stimulate aldosterone secretion by itself. So not only will aldosterone come out via the renin system, but if potassium by itself starts to go up, aldosterone comes out. Why is it important that aldosterone comes out? What's aldosterone going to do to that potassium? What does aldosterone promote? Sodium reabsorption and potassium loss. That's what it does. It promotes sodium reabsorption where water comes along with it, but it dumps potassium into the urine. So if we have high concentrations of potassium in the blood, we have to get rid of it. The way we get rid of it, aldosterone comes out and pushes that potassium into the urine, and that will lower your potassium. So that's how aldosterone works just for potassium concentrations alone. So we can increase cell uptake of potassium in our skeletal muscle. That can also get rid of extracellular fluid, or we could excrete more potassium via aldosterone. So in patients who have chronic renal failure, hyperkalemia is an indication for hemodialysis. So those of you who have worked in the ER, you'll see these patients come in with dialysis, but they haven't gone for a few days, and they just show up on a Friday, and they're like, I haven't had dialysis all week, and their potassium is like 6, 7. They need to go for dialysis to get rid of that potassium because the kidneys can't do it. These are just the steps, things that we can do. We're going to learn about these as we go, but insulin will push potassium back into the cell by itself. We say give insulin and glucose because if I give you insulin, what's that going to do to your blood sugar? Drop it. I don't want you to drop your blood sugar. You're not diabetic. You just have too much potassium. So if I give you insulin, it'll take care of the potassium for me, but if I give you glucose with it, your sugar won't bottom out. So the glucose is just a patch because the treatment you're giving is going to cause hypoglycemia. So let's just give you some glucose along with that. Kxalate, it's a chelator. Chelators attach to ions, and they come out of solution, and then you get rid of them. Okay, so that's one way we can do it, and kxalate increases fecal potassium elimination. Things we can do to get rid of that excess potassium. Beta-2 agonists can also cause potassium to be shifted, and it'll drive it back into the intracellular fluid. So these are some chemical ways with drugs we can get rid of your potassium. So internal, insulin will move ECF to ICF, epinephrine as well, ECF to ICF. Here's your insulin, here is your epinephrine, and it'll also cause some acid-base balance issues as well. With acidosis, okay, hydrogen is buffered by the ICF and is associated with potassium efflux from the cells. So potassium is going to leave the cells, increasing plasma potassium. So with acidosis, you get hyperkalemia because of this hydrogen ion being buffered. So with acidosis, you get hyperkalemia because of buffering of the hydrogen. With alkalosis, the hydrogen exits a cell in exchange for potassium, reducing plasma potassium. So with alkalosis, you get hypokalemia. Because in an alkalotic environment, we need those hydrogen ions to buffer the acidity. We have to get them back into the blood. When we get them back in the blood, we're going to dump potassium into the urine because it's the exchanger, hydrogen, potassium. So that's what's going on with alkalosis and your acidosis. And we've already learned about aldosterone. Just it's a natural way to get potassium back into the cells. So these are 4 ways we deal with internal potassium homeostasis. Insulin, epinephrine, what happens during acid-base disturbances, and aldosterone. Those 4 things are ways we can alter our extracellular concentration of potassium and get it back inside the cell. So our renal potassium handling, our 70% will be reabsorbed in the proximal tubule, 25% in that ascending loop of Henle, and then we get to the late distal tubule and the collecting duct, and you see here negative 200 to about 10%, and the fractional excretion can be altered between 0 and 200%, all depending on what's going on in the blood with regards to potassium. So we can really alter our excretion of potassium, because remember, what's it called if we add something into the tubular fluid outside of the Bowman's capsule? Secretion. We're going to secrete more potassium back into the tubular fluid at a later point, common collecting duct, late distal tubule, to either bring more potassium in or excrete it and get rid of it. So, secretion of potassium from our cells in the late distal tubule and your coracle collecting duct is the most important determinant of your urinary K output. And again, why? It's under hormonal control. So we can alter that potassium based on the hormone and what we need in the body. Okay. Net reabsorption of potassium is also possible in the collecting duct in the states of potassium depletion, because what's going to happen is we're going to reabsorb potassium in exchange for hydrogen via that hydrogen potassium ATPase pump. Okay? So potassium depletion, we reabsorb potassium in exchange for hydrogen. This one you guys can do as a good study guide, so I'm not going to do all this one. Now, when we talked about diuretics, we talked about we shut them off, all those ions are going to stay in the urine. So when we shut off the thiazide or loop diuretics, they're going to inhibit sodium reabsorption. So all that urine is going to be highly concentrated with sodium because we're not going to reabsorb it because we have thiazide or loop diuretics that we're giving someone. So the sodium is going to stay in the tubular fluid in the urine. It's going to start building up. As this starts building up, we get high sodium delivery, which gets to the cortical collecting duct towards the end because it's not getting out of the urine, it's staying in the urine because we gave a diuretic that blocked it. So that sodium is staying in that tubular fluid and it goes along the ride over the whole entire nephron. When all this excess sodium hits that cortical collecting duct, it drives further potassium secretion. And that's going to decrease extracellular fluid of potassium. Which is why when you give a thiazide or a loop diuretic, you have to check potassium. Because when you give these two types of diuretics, that sodium is going to go along for the ride. When it gets to the CCD, it's going to cause more potassium secretion, causing hypokalemia. Because the potassium is going to go into the urine, and we get rid of it. That's why if people have problems with their potassium on a loop or a thiazide diuretic, what other option of a diuretic can we give them? The last one we learned about, the potassium-sparing diuretic, because that one is aldosterone or a aldosterone antagonist. So it's going to do the opposite of aldosterone, but it's going to keep potassium in the blood. Remember, aldosterone has a sodium, aldosterone causes sodium reabsorption and potassium loss. So if I give an aldosterone antagonist, I'm going to keep sodium in where? In the urine. If sodium's in the urine, what's also going to stay in the urine? Water. So we're going to cause a diuresis. But that potassium is being reabsorbed into the blood, so you don't lose potassium with spironolactone, an aldosterone antagonist. Yes, you have a question?
Is that preferred to just like giving potassium supplements with a diuretic?
It depends on the patient. We'll get more to that later on, but you don't want to you don't want to keep giving them more medication to treat what you're giving them. You can just solve both with one pill. They're not as strong, but we give them. Any other question back there? Kevin? Okay. Also, we have these fixed acids or anions. They're normally not there, but again, during metabolic alkalosis, so we're in an alkalotic environment, we have a large bicarb load in the tubules. Okay, metabolic alkalosis, we have too much alkaline, so the bicarb is a problem. Causes increased secretion of potassium. If we're increasing the secretion of potassium, where is it going from what to what? Secretion, where does that go? From where to where? Blood into the urine. Okay, so we're increasing potassium secretion, therefore you're going to decrease your extracellular potassium. So these are ways we can alter the potassium. How diuretics alter potassium, because when you cut off all those transporters, sodium stays in the urine. When all that excess sodium, which normally comes back out, we stopped it artificially with a drug, so the sodium is going to stay in the tube. When all that excess sodium goes to the collecting duct, it causes more potassium to be released, so you lose potassium. That's what's going on in this one for diuretics. This is a good summary slide for you guys as well, as far as what goes in, what comes out in different areas. You have the real one in your drawing, so this is a good review. And let's take a break. Come back at 1:25. Okay, so I promised you guys when we did the palm section that we would just introduce acid-base. We're going to do a lot of it here when it comes to the renal system to really put things together with the lungs and the renal system. PAs, great review because you got your clin lab exam next week, which is all the renal stuff acid-base anyway. So it's a great review for you guys. So remember our normal plasma pHs, 735 to 745. Our pH is regulated by our breathing, getting rid of CO2, and via our kidneys by varying the hydrogen excretion and obviously bicarb production in the kidney. The kidneys will also create bicarb as well. So I know we have bicarb with the whole carbonic anhydrase formula. Make sure you understand that. Where does the reaction occur in what direction, depending on if you're in the lungs or in the tissues? Okay? Remember, in the tissues, CO2 is being produced, so it combines with water through what enzyme does it go? Carbonic anhydrase, and it turns into carbonic acid, H2CO3. Then, through carbonic anhydrase again, that gets turned into what? Bicarb, HCO3 minus, and a hydrogen ion. That happens at the tissues. That's how you get bicarb and hydrogen out. When we get to the lungs, we have to do the opposite now. We get that bicarb back into the cell via what? Reverse chloride shift at the lungs, which allows bicarb and the hydrogen to go back into the red blood cell. They combine via carbonic anhydrase to make the carbonic acid, which then through carbonic anhydrase again turns into CO2 and water. CO2 leaves the red blood cell and we exhale it off into the lungs. So for your test tomorrow, understand all that. Normal values, again, you'll have that on your exam as well, your normal lab value. So it's 40 for CO2, easy to remember, just 40. And about 24, 28-ish for your bicarbs. Acids and bases, just know acids will release hydrogens into solution, and bases will accept it from their solution. Most of our acids and bases in physiology are considered weak. They will release or accept fewer hydrogens. The limit of pH is 6.8 to 7.8. That's the limits. Anything below or higher than that, our physiological processes don't work very well because of the acidity or the alkalinity that's going on. So we have to be able to defend against disturbances in pH. We have a couple of systems for that. We have buffers, but they're limited, but they are immediate to help buffer the pH of the blood. We can change ventilation. That occurs obviously seconds to minutes. That's your second line of defense. We can alter our breathing very fast. The renal excretion of hydrogen and bicarb synthesis is the final line of defense. Takes a period of hours to days to prevent this change from happening. So it's a slower response with the metabolic, intermediate response, moderately fast response with the lungs, and we have buffers which are more immediate but don't last as long. Okay. In our blood, we use bicarb as the buffer. Bicarbonate is our buffer, and again, through this reaction, because we know that HCO3 will bind to hydrogen to make that carbonic acid. So if the pH increases due to an increase in bicarb, if we increase the bicarb, we're making our pH more alkalotic. It's a base. That's going to be your metabolic alkalosis. If it's an increase in your bicarb, because we're trying to offset that, or it's going to be a decrease in your PCO2. Remember, CO2 is the acidic. If CO2 is going down, that favors an alkaline environment. And this will be respiratory alkalosis if the CO2 is abnormal and low. If the pH decreases, Now we're becoming more acidic. Due to a decrease in bicarb, we don't have enough bicarb to buffer it out anymore. The hydrogens are going to win out. pH drops, become acidic. Because the derangement is due to the bicarb, it's metabolic. Or you can also have an increase in PCO2, and that's your respiratory acidosis. That's towards the end there. Okay? So the first thing we have is just bicarb. That's our first buffer. The respiratory contribution, obviously, it is in our breathing rates. Hypoventilation, low breathing rates, builds up carbon dioxide because we can't blow it off. Respiratory acidosis. Hyperventilation, anxiety attack. Okay, hyperventilation, we're blowing off all that CO2 now. CO2 starts to drop in the blood, causing a respiratory alkalosis, because it's returning the pH is going to be more alkaline. Now, we can alter the breathing to compensate for metabolic acid-base problems. So how do we compensate? So if it's a metabolic issue, we change our breathing to accommodate for the excess CO2 or there or whatever going on. We can alter our breathing to compensate for the metabolic disturbance. Low plasma pH, so low pH by itself will stimulate to increase ventilation. Does that make sense? Okay, we have low pH, so we're acidic. We have to get rid of the acid. Let's blow off CO2. Increase ventilation, we start blowing off more CO2. We decrease the CO2 in the blood, and the acidity goes back down to normal. Increases in plasma pH cause smaller changes in alveolar ventilation, since low ventilation rates can compromise oxygenation of the blood. So we don't want you to hypoventilate to the point where we're not oxygenating the blood anymore. So that's what the increase in plasma pH doesn't have that big of an effect, because we don't want you to stop breathing to raise your CO2 levels. Because then if you go too low in your respiration, then you're going to have problems with your oxygen. Because remember, whatever you're breathing, oxygen is there, and so is carbon dioxide. So we don't want to have you hypoventilate too low, because then you'll stop breathing and you'll get enough oxygen and you pass out. So this graph right here, here is your normal pH 7.4. You see here, look at the big rise in breathing. Here's your alveolar ventilation. As you get to the acidic part, very steep rise. But as we start going to the basic, the alkaline, where pH starts to increase, we don't want to drop your ventilation too much because of oxygen. So you have a smaller decrease in ventilation with higher pHs. And it's all because of oxygen. We don't want to drop it too much where you're not getting enough oxygen in. So renal regulation now of plasma bicarb. The renal system can excrete bicarb, and it also can generate new bicarb, depending on what's going on. Under normal circumstances, the renal venous blood will have more bicarb than the renal arterial blood. Why is that? Why is the venous side going to have more bicarb than the arterial end going into the kidneys? Kidney can make its own. So the kidney is right in the middle. It's making its own bicarb. That's why there's more bicarb on the venous side of the renal system, because the kidney is making bicarb. It's going to go into the bloodstream. So it's higher on the venous end because the kidney creates more bicarb. And usually the kidney, under normal situations, will generate just enough bicarb to neutralize any acid from metabolism. So normally, again, all systems are working appropriately. Acid, our pH is neutral or within normal physiological ranges, and everything's okay. The other thing that the kidneys can do is that it can excrete fixed metabolic acids. Acid in the urine is mainly in the form of ammonium, NH4, And here's your phosphorus acid, H2PO4 minus. These are fixed acids that if our blood is too acidic, we can get rid of these to reduce the acidity of the blood. So these are a couple of things that our kidneys can do to help get rid of more things, more acidity, to reduce the pH or increase the pH. So renal regulation. Here is the lumen. So that's where the urine is being formed. That's the ultrafiltrate going through the entire nephron. We have our proximal tubule cell. Okay, this is the wall, and then therefore you have your blood. Here's all the filter that comes in. We have bicarb, we know, being dumped into the urine. It's a normal process. It's a normal ion. It gets dumped in there. It combines with the hydrogen from the sodium hydrogen exchanger to make your carbonic acid. Same process with carbonic anhydrase. Remember, where was the effect of those carbonic anhydrase inhibitors on that diuretic chart of the whole nephron? They're only in the proximal tubule. We are in the proximal tubule, and this is where carbonic anhydrase is. So when you give carbonic anhydrase inhibitors, it only works at the proximal tubule because that's where carbonic anhydrase is. It's nowhere else in the tubule. So obviously with that mechanism, we get bicarb, and, water and CO2. CO2 goes into the proximal tubule cell. Same reaction occurs. But if you notice, 3 bicarbs are generated going into the blood. When this bicarb, or this carbonic acid dissociates, the hydrogen goes there, which then goes into that part. The bicarb goes out there, but it's 3 of them get exchanged out for 1 sodium. So 3 bicarbs for 1 sodium in the blood, and we get bicarb generation going into the venous renal system. Okay, so as 1 bicarb went into the lumen, you get 3 out. That's how the kidney is able to generate bicarb. And that's why bicarb is higher on the venous end, because the kidney is going to create their own bicarb. They create 3. Okay, so this is what's going on with bicarb, and most reabsorption of the bicarb will occur in this early proximal tubule. So this is what I was talking about before with these carbonic anhydrase inhibitors, acetazolamide, which disrupts tubular bicarb reabsorption. And don't worry about the rest. So acetazolamide is the drug you give for high altitude mountain sickness. If any of you want to do like environmental medicine, I know we do have a couple of PAs who graduated that work in like wildlife and do all the environmental stuff. Let's talk about ammonia now, NH4. Okay, remember this is one of those titratable acids we can get rid of. Net effect is excretion of acid in the urine, and it generates new bicarb as well to replenish anything that was lost. So again, we're in the proximal and distal tubules here with regards to nitrogen, NH4, ammonia. Okay? Don't worry about everything in the middle. Just everything happens magically. Just know when we put an ammonia into the lumen, we're going to create more bicarb. Again, it's a way to create more bicarb. We're losing an acid and we're creating a base. Titrating your pH, depending on what's going on. If we're too acidic, we can dump more NH4 ammonium into the urine, get more bicarb out to neutralize our pH again. Does that make sense? How we get bicarbs? Why the kidney can generate extra bicarb? Here's more of our titratable acids. This is phosphoric acid. Very similar setup as far as the other one we did up here. with the bicarb. We're still in the cell, carbonic anhydrases here, all this fun stuff going on. Again, proximal tubule, because the proximal tubule is where the carbonic anhydrase is. That's where those carbonic anhydrase inhibitors work. So again, same thing, we have HPO2 minus, which is your phosphate. It combines with a hydrogen that's, again, created within the tubular cell through the work of carbonic anhydrase to create a hydrogen, which is what binds the phosphoric acid to make H2PO4 minus. Again, we're able to titrate our hydrogen ions by binding them to the phosphate. And then we can get rid of it. It's a titratable acid. We can add more H to that, binds to the HPO4 2 minus, becomes H2PO4 1 minus because we added a hydrogen, and we can get rid of that acidity in that direction as well. And again, we create 3 bicarbs. Again, we're creating more bicarb to help offset the acidity of the blood. We have to get rid of the acid. Let's get more bicarb going to neutralize. Remember, bicarb is our immediate buffer for the extracellular fluid, bicarb. By having more bicarb be generated, helps offset the acidity of the blood. So acidification of our urine occurs along the entire renal tubule. Our proximal tubule will secrete most of the hydrogens, but the pH does not decrease below 6.8 because of our bicarb buffer. Cells in the loop of Henle, distal tubule, and our principal cells in the common collecting duct all secrete hydrogen via that sodium hydrogen exchanger. So again, if we're adding hydrogen to the tubule fluid, we're making it more acidic. So we're acidifying the urine along the entire length. Anytime we can add a hydrogen or an acid, we're acidifying the urine. Remember, we don't like acidic blood. We prefer to be more alkaline. Things work better in our body in a more alkaline environment. I know a lot of hospitals in Japan, they all have this alkaline water that they give to all the patients. It helps drink, it helps with medicine absorption because you're giving an alkaline drink with it. Although, to be honest, I don't know how much of an effect it really has because the pH in your stomach is like 2. So adding a 7.6 pH drink in an already acidic environment, I don't know how much that's really going to affect it, to be honest. By drinking alkaline water, I don't know how it affects it. If someone else knows, but knowing physiology and knowing how things work, does it really happen? I don't know. But you guys, as you're seeing all this crap on YouTube and TikTok, all these people, they all have medical influencers, 90% is garbage. Listen to it now, like slow them down, like you can tell, like they know a little bit, but they don't know the whole story. When they try explaining it, they make a lot of mistakes. And so be critical of people that do stuff like that. They're not doing good stuff. And also in our common collecting duct, hydrogen secretion via hydrogen ATPase, and there's our hydrogen ATPase potassium, hydrogen potassium ATPase pump as well. So again, acidification of the urine, adding hydrogens can occur along all parts of the nephron. We have the ability to get rid of acidity from the blood, dump it into the urine to get rid of it. Remember, the body doesn't care about the concentration makeup of the urine. It's all waste products. Get rid of it. Again, so here's our sodium hydrogen exchange in the distal tubule, and this is under aldosterone effects. So therefore, excess aldosterone can be seen with metabolic alkalosis because we're dumping a lot of hydrogens into the urine. So having too much aldosterone can also cause some problems as well. This will not be on your exam, it's just again showing what aldosterone can do. Okay, so let's talk about acid-base regulation. Okay. So the first thing that happens, So number one at the very, very top is we have acid production by tissues. And this is the tissue. Here's your interstitium. And there's your blood. So our tissues create CO2, sulfuric acid, and phosphoric acid. All these are basically hydrogen ions. So we group them all together, they're going to create hydrogen ions, making the blood more acidic, because we're having all this hydrogen being created. Okay? Then in the second part, we have acid buffering. How do we buffer? In the intracellular fluid, we can buffer it with proteins and organic phosphates. So within the cell itself, we can treat the acidity with proteins and organic phosphates. When it gets into the interstitium, or the extracellular fluid, what's the major buffer system we have? How do we buffer? What's the major buffer in the blood? Bicarb. And phosphate will do it as well. Remember, phosphate, we have phosphate going into the lumen of the renal tubule. We talked about phosphoric acid. It just grabs a hydrogen, binds to it, and gets rid of the acidity that way with phosphate. That's how phosphate works, or phosphoric acid, to neutralize as a buffer. So the hydrogens can get buffered by the ICF, hydrogens can get buffered by the ECF. And in the blood plasma, what binds to hemoglobin that we can get rid of acidity? Hydrogen. Hydrogen will also do it. So in the red blood cell, we have hydrogens, or hemoglobin, I'm sorry. Hemoglobin will bind to a hydrogen ion. So the red blood cell itself can also do some buffering capability, but just know the biggest one is the bicarb. That's the buffer system that we have. So let's talk, the last thing we have to talk about is how do we get rid of the acid? Acid removal. For our respiratory component, what do we have to do to get rid of acid? Hyperventilate, increase the breathing rate. So a decreased pH, what does that do to our ventilation when a pH drops? Increases. Remember that graph we went through before? We don't like pH being low. We don't like acidity. We have to get rid of it. So low pH increases ventilation, which will eventually lower your PCO2. And that's how we can get rid of acids through the respiratory system. We can also get rid of acids renally. Okay, ways we can do that. We can reabsorb bicarb. So we add more bicarb into the blood. It'll bind to those hydrogens, and we can buffer the system that way. The other way, increased excretion of those titratable acids. Ammonia, phosphoric acid. Those are titratable acids. When they're in the lumen, they'll bind to a hydrogen and get rid of the acidity. So what happens along the way? We can, obviously, we want to reabsorb bicarb. So the blue line going back out if it's happening outside the Bowman's capsule, so that blue arrow leaving, what is that? What's the definition for that? Reabsorption. It's happening outside the Bowman's capsule. We're reabsorbing that bicarb. What can we dump into at this proximal tubule? We can dump in NH4, ammonia. We could dump it in, and when we dump it in outside, what's that called? Secretion. We can secrete more of these titratable acids. Ammonia happens at the early proximal tubule. In the loop of Henle in the ascending, we also have ammonia here as well. So it can go there, and it can also get dumped into there. Here's our phosphoric acid. And lastly, bicarb. So these are the ways, again, how do we get rid of acidity in the blood? The kidneys will do these things. More bicarb in the blood. Remember, the kidneys can create bicarb, which will offset the low pH. Titratable acids, ammonia and phosphoric acid. We can leave them in the tubular fluid, and it'll bind to hydrogens and keep the hydrogens in the urine, getting rid of it so we don't reabsorb the hydrogens, making the blood more acidic. We want to get rid of the acidity. Keep the hydrogens in the urine by binding it to ammonia or the phosphoric acid. That's why those are titratable acids. We can titrate them up depending on what we need to do with our acidity. Okay, so that's how we can get rid of excess stuff. So let's talk about this hydrogen-potassium interactions. Many cases, there's a reciprocal relationship between secretion of hydrogen and potassium in the common collecting duct. Remember, with acidosis, okay, where do we want to put all the hydrogens? Where do we want them to go? Into the urine. So when we do that, we have an exchanger here. One goes up, the other one goes down. So if hydrogens are getting dumped into the urine, where is the potassium going to stay? In the blood. And that's why with acidosis, you have hyperkalemia. With alkalosis, do we want to lose those hydrogen ions from the blood during an alkalotic environment? No, we want to keep the hydrogens in the blood. So this exchanger starts dumping potassium into the blood, into the urine. Because we want the hydrogen to build up in the blood to buffer the alkalosis. So that's why with alkalosis, you get hypokalemia. The only time this doesn't happen is diuretic use. Okay? When we have diuretic use, we have an increased load of sodium staying in the urine, going to stay through the whole tubule, and it goes to the common collecting duct, which we learned before. When we have an increased sodium load going to the common collecting duct, we dump potassium and hydrogen, both go into the urine. So the only difference is secretion of both hydrogen and potassium. Normally it follows the other way. The only difference is when you have a diuretic. So acid-base disorders. Respiratory disorders are based on arterial PCO2. PCO2 is greater than 45, respiratory acidosis. And if it's lower than 35, we're in an alkalotic environment, but the CO2 is off. If the CO2 is off, it's respiratory. If the bicarb is off, out of ranges, it's alkalotic, or metabolic, I'm sorry. So metabolic disorders are always based on your bicarb. If the bicarb is low, that means we're using up a lot of bicarb to neutralize a lot of acid. Metabolic acidosis. If the bicarb starts to build up, we have too much bicarb, making our pH higher. We have all this excess bicarb floating around, causes a metabolic alkalosis because now bicarb is way too high. Bicarb is created by the kidneys. It's a metabolic process. So we're going to go through this. This is for you when you're studying, but we've kind of, remember, always start with the pH and go from there. If the pH is acidic, your answer has to be an acidity. If the pH is alkalotic, the answer has to be alkalotic. Then you just look at the CO2 and the bicarb and see which one's out of whack. And I have examples here we're going to go through. So metabolic acidosis. What are some causes? Excess production or ingestion of fixed acids. For example, ketoacidosis in diabetics. We're adding in ketones that normally aren't there. Ketones make your blood more acidic. Okay? Lactic acid buildup. Lactic acid is normally not there. This is produced by metabolism, anaerobic metabolism. Lactic acid builds up, blood becomes more acidic, but it's metabolic acidosis because we're creating it metabolically. Kidney failure will do it, and ingestion of poisons. Okay, ethylene glycol, antifreeze. Okay, those are acids that normally shouldn't be there, anions. So you would see an anion gap with some of these. That's what an anion gap means. There's some extra solutes there that shouldn't be there. For example, in this case, ethylene glycol. So with metabolic acidosis, we compensate with the opposite one. I don't know what the word is. If it's a metabolic derangement, we compensate respiratory. If it's a respiratory problem, we compensate metabolically to offset those changes. So the compensatory respiratory alkalosis is usually present, reduces CO2, and will hope to increase your pH towards normal. That's the compensation. So resolution of metabolic acidosis without treatment means we have to generate new bicarbs, increase hydrogen excretion via, again, ammonia production. It's a titratable acid. We can bump a hydrogen on there and get rid of it. So those titratable acids, they bind to hydrogen, they get rid of the acidity. Also caused by loss of bicarb in the diarrhea. So patients have diarrhea for a few days. They're going to be metabolic acidotic probably because they're losing a lot of bicarb in the diarrhea. Here's your anion gap. Obviously, it's going to be higher because you have a bunch of different acids in there. Usually, an anion gap is about 8 to 16. I'm not going to have you calculate it, but if you hear an anion gap, that means there's something else extra there that should not be there. So here's an example. Okay, a 16-year-old girl with diabetes was found unconscious and unresponsive. Here are the blood gas analysis. PO2, 90, is that normal or abnormal? Normal. 90 to 100 is a normal PO2, so that's okay. PCO2, 36. Normal, it's okay. Bicarb, really low. pH, low. Plasma sodium is okay, chloride's okay. Anion gap, high. We have something else going on with this patient. So, what is the pH? Acidic or alkalotic? Acidic. Which of the two is the derangement, the bicarb or the CO2? The bicarb. We know this is metabolic acidosis because the bicarb is the one out of whack, and the pH tells us it's acidosis. This patient has diabetic ketoacidosis, produces an anion gap, and metabolic acidosis. Everyone understand why it's metabolic acidosis based off of the labs? Good. Let's talk about metabolic alkalosis now. Most common form of metabolic alkalosis Vomiting. We lose a lot of hydrogen in vomitus. Remember, hydrochloric acid is our gastric acid. All those hydrogens that are in our stomach waiting to be dissolving whatever food is, when you vomit, you lose all that. So then the bicarb starts to build up in the blood because there's no proton to bind to. So it's a net gain of bicarb. Okay, it's called contraction alkalosis. Aldosterone levels also are increased when affecting circulating volume is low. So obviously, if you're vomiting a lot, you're going to get dehydrated. So volume goes down. So we get increased hydrogen secretion by the distal nephron because aldosterone levels are changed as well. So we got an increase in arterial pH, alkalemia, and we got a compensatory respiratory acidosis. So we compensate metabolic alkalosis with respiratory acidosis. How do we cause respiratory acidosis? What do we have to do? Hypoventilate. That's what happens. Your breathing rate slows down to allow you to build up the CO2. Okay. Don't worry about this one. Just talk about fluids. Okay. Here's our example. A 2-year-old child, lethargic, dehydrated, has 3-day history of vomiting. The results of the ABG are as follows. PO2, is that normal? Yes. We're good. PCO2, 44. Normal, we're good there. Bicarb, high. What's the pH? High as well. Do you see how it's metabolic alkalosis? Bicarb is deranged, pH is alkalotic, metabolic alkalosis. Okay, metabolic alkalosis due to loss of your gastric fluids, and that's it. Respiratory acidosis usually can be due to inadequate ventilation causing CO2 retention. Neuromuscular disorders, airway obstructions, narcotics that make you slow your breathing rate down. Anything, again, that's inhibiting will cause your breathing rates to go down. So those benzos that inhibit, remember that they activate the GABA channels, and GABA opens up what? Chloride to travel. Chloride's negative, makes the cells more negative. So if respiratory acidosis is acute, there's not enough time for renal compensation. Remember, the metabolic compensation, the metabolic buffer system is very slow. Takes hours to days to have an effect. So if the respiratory acidosis is acute, there's not enough time for renal compensation. So with chronic respiratory acidosis, now the renal system has enough time to normalize the pH by excreting more acids and producing more bicarb. Remember, the kidneys can make bicarb. It just takes a little bit of time to happen. So in an acidic environment, eventually, we'll start making more bicarbs to offset and excrete more acid to try and compensate for that respiratory acidosis. So here's an example. 24-year-old male, known heroin addict, was found unresponsive with a needle in his arm. And here are the ABGs. PO2, very low. Why is it so low? He's not breathing enough. This is why we don't like having the high pHs. We don't drop our respirations too much, because we don't want to cause a problem with hypoxemia. PCO2, very high. Bicarb, normal. pH, acidic. Respiratory acidosis. Everyone good? So this one, respiratory acidosis with no metabolic component. Why? Our bicarb was normal. So we're not making any more bicarb because the range is normal. Bicarb is normal. And obviously, this is an acute situation. They're on narcotic, respiratory depression, hypoventilation, causing respiratory acidosis. Okay? Respiratory alkalosis. Okay? Now we have excessive ventilation, greater CO2 loss than production. This is a response to hypoxemia, high altitude, psychogenic hyperventilation. What's that? Anxiety attack. Psychogenic, the psychomental genic, the cause, the beginning, anxiety attack, caused hyperventilation. That low arterial PCO2, because we're blowing it all off, also decreases plasma bicarb and your hydrogen. Again, with your respiratories, if they're very acute, there's going to be no compensation because there's no time for the kidneys to start changing what they need to do. In chronic, renal system will normalize pH, excreting less acid and producing less new bicarbonate. We want to get rid of the bicarb. We're already alkalotic. So let's bring in more hydrogens back into the blood to offset the alkalotic environment. And let's stop making new bicarb by the kidneys to allow more acidity to offset the pH. So those are ways we can compensate with respiratory alkalosis. So here's an example. 56-year-old male suffered a panic attack while waiting for surgery. Here are the gas analysis, ABGs. So PO2, why is it so high? It's hyperventilating. So obviously you get more oxygen coming in, it's going to go up. Is it of any consequence to what we're doing with our metabolic and respiratory acid base? No, but it confirms, yes, they're breathing too much or breathing too little by what those PO2 values tell you. PCO2, normal or high? A little bit low, but not much, but I'll tell you what happens in a second. Bicarb, normal, pH, high. So pH is high, CO2 is low, respiratory alkalosis. Okay. This is respiratory alkalosis with no metabolic component because our bicarb is normal. We haven't started changing anything with that bicarb. If patient's panic attack resulted in acute hyperventilation and obviously respiratory alkalosis because they're breathing very, very fast. And acid-base abnormality will return to normal once their breathing returns to normal as well. So again, it's an acute environment. Once their breathing comes relaxed and controlled again, the respiratory alkalosis will go away and your pH will go back down to normal. So compensation of these acid-base balances refers to responses that want to normalize your pH. We have to get that pH back to normal ranges. So compensation is usually not complete. And because it doesn't complete all the way, we can still find out what the primary cause of this acid-base disturbance occurred. Was it respiratory or was it a metabolic? How do we figure that out? If both alkalosis and acidosis are present, which you could have depending on what your CO2 and your bicarb are at the time, but the pH is still acidic, acidosis must be considered the primary disorder and partially compensated by the alkalosis. So the pH will still tell you, is this a metabolic or a respiratory or acidotic or an alkalotic cause? So always look at the pH first. So tips for determining compensation. If the pH is normal, what about the CO2 and the bicarb? So what we need to do, let's go to a highlighter. Which component matches the pH? In other words, which component is acidic if the pH is acidic, and which component is alkaline if the pH is alkaline? This tells you where the problem started. Okay, The other component will be abnormal to compensate for the component that started the problem. I have examples, so don't worry about it if you're confused right now. So, compensation, the first one, pH is acidic. PCO2 is acidic. Does that CO2 of 55, you understand why that's acidic? It's high, it's acidic. When CO2 is very, very low in the range, it's alkalotic. Bicarb is 31. 31 is a high bicarb, right? Normal is up to 28. So a high bicarb means we are alkalotic. Everyone good so far? Understand alkalotic, acidotic with those values. So the interpretation, respiratory acidosis, because those match, with the kidneys compensating. We are respiratory acidosis, the compensation is going to be metabolic. To get rid of the acidity, we have to cause a metabolic alkalosis, so bicarb goes up to offset the acidity as a compensation to the acidity. Is everyone okay on that first one? Make sense? Let's go to the second one. pH is 748, that's alkalotic. PCO2 is still 50, that is acidic, it's higher than 40. HCO3, the bicarb, is 35, which is also alkalotic. What are the two components that match? pH and the bicarb. Metabolic alkalosis, because it matches the pH, and the lungs are starting to compensate for that. Everyone understand how that works? Here's a really easy mnemonic I'll give you in a second. Don't worry about that. Here's an example. And I'll give you a mnemonic at the end. 42-year-old male, chronic renal failure, being treated with hemodialysis. Here are the numbers. PCO2, is that normal? Relatively. A little bit on the lower end, right? Bicarb. pH. Well, so remember, we're compensating, but 735, more on the lower end, right? So this would be more, you consider this more acidic. Anion gap is normal. So, which one, the bicarb or the CO2, which goes along with the acidity? Bicarb. Okay? Why is the bicarb the cause with the acidity? Where's the bicarb going? Being used up, right, to try and buffer. So, what is the primary, if I said, and this is your scenario, here's the lab work, what is the primary derangement for this patient? Metabolic acidosis. The metabolic matches the acidity. What's the compensation for this one? Respiratory alkalosis. CO2 being low. Is that alkalotic or acidic? Alkalotic. We're low. So what do you think this person's going to do with their breathing to compensate for this metabolic acidosis? They're going to increase their breathing rate to offset the metabolic acidosis. So this is metabolic acidosis with respiratory alkalosis with a normal pH. Okay. We consider respiratory component compensation complete because the pH was normal. But even if it's normal, 735 to 745, on your exam I will not give you that ambiguous. I'll make it like 7.2 or like 7.5, so you'll know that it's really out of range. But if the pH goes back to normal, but it's on the higher end or the lower end, find the component that matches it, and you go from there. So, metabolic acidosis. Expected respiratory compensation is hyperventilation. On the bottom, the red arrow is the primary disorder, the blue is the compensation. So metabolic acidosis, we know the red is the primary problem, so metabolic acidosis is low bicarb. The compensation is the blue, CO2. Metabolic alkalosis will cause hypoventilation as your compensation. pH is going to be low. See, bicarb is the problem here. This is a metabolic alkalosis. The red arrow is the primary disorder. So this is bicarb. We compensate via respirations. With a respiratory acidosis, we're already in a respiratory problem, so the compensation has to be metabolic. That's high, and that's high. And then the opposite is true for respiratory alkalosis. We compensate metabolically via changes with hydrogen excretion. We want to bring that hydrogen back into the blood. So we're not going to excrete into the urine the hydrogen. We need it back in the blood to offset the alkalosis. And obviously, we're not going to make enough bicarb because we don't need more alkaline material going into the blood. We want to reduce the bicarb that we generate to allow the acidity to come back up. So in this case, the primary disorder follows the acid base. This you can do on your own, but this I want you to see this one. The Rome mnemonic. With respiratory, they're opposite. Respiratory is opposite, metabolic is equal. Meaning, in alkalosis, in a respiratory alkalosis, the pH is up, the CO2 is down. They're opposite. In respiratory acidosis, the pH is down, the CO2 is up. They're opposite directions. For the metabolic stuff, they're equal, the same direction. In alkalosis, pH is up, bicarb is up. So a really fast way to look at them this way as well. In metabolic acidosis, pH is down, and your bicarb is down as well. So respiratory are opposite. pH and CO2 are in opposite directions. For metabolic derangements, the pH and the bicarb are in the same direction, either both up or both down. But they're in the same direction. So by going back to this one, up, what's the primary? Well, that's pH, that's hydrogen, but wait a minute, I'm confused. Let's go look at compensation. So when you're looking at these again, just look at the acidity, pH, where acidic or alkalotic, CO2 or bicarb, which one matches that acidity or the bicarb. So here you go. And let's finish today. We'll do the last little bit on Monday, and we'll start GI on Monday. I'll make an announcement later, let you know what time, probably like 8 to 9:30 tonight. And then test tomorrow morning. Good luck, guys, studying.